Hi, my name is Candace Benner, and I'm a family nurse practitioner who has subspecialized in ears, nose, and throat for the last 14 years. You are getting ready to view the third module out of 5 that I have created to help nurse practitioners and physician's assistants evaluate common ears, nose, and throat complaints. Upon completion of the module, the clinician will be able to identify the source of the patient's Otalgia and understand the implications, if there are any. Identify diagnoses that need additional evaluation and what that evaluation includes. And lastly, determine if the guidelines as recommended by the American Academy of Otolaryngology Head and Neck Surgeons has been successful. Otalgia can affect all age groups along the lifespan. Ear pain can arise from the ear itself or occur as referred pain. It is essential that the clinician be able to recognize and evaluate otologic ear pain as well as referred pain effectively. Ear pain can be divided into acute and chronic conditions. In addition to, it can be subdivided into infectious, inflammatory, and traumatic, although there may be overlap amongst these categories. There are 2 theories involving referred pain, including dermatomal and convergence projection theory. It is not the intent of this module to discuss those 2 theories in detail, but I have listed additional readings in the recommended reading section if you are interested in gaining more knowledge. On the next 2 slides, I have provided differential diagnosis that the clinician should consider when assessing a patient with Otalgia. Each diagnosis lists physical exam findings that one might see, as well as treatment options that are available should you decide that diagnosis is the correct one. On slides 7 and 8, I have provided clinical pearls that I have learned along the way while treating and evaluating patients for Otalgia. On this particular slide, I'd like to point out a couple of additional items. Such as under otomycosis, manual debridement will be necessary in order to resolve and rid the patient of the fungal infection. Once that has been completed, I will oftentimes place ketoconazole cream in the external canal to help with treatment of the otomycosis. One could also utilize acetosol drops to try to neutralize the pH in the external canal. Under furunculosis, oftentimes topical heat and application of Bactroban will resolve the lesion itself. Under foreign body, particularly if it's an alkaline disc battery, prompt removal is necessary because it can cause excessive tissue damage that can occur if it's left in place. On this slide, I'd like to point out a bullous myringitis is a very uncomfortable and painful lesions to the tympanic membrane. It's oftentimes necessary to treat this patient with oral antibiotics as well as antibiotic ear drops and provide analgesics because of the discomfort. Adult who presents with an acute otitis media, it's very important to make sure they have a precipitating event such as a significant sinus infection or even upper respiratory tract infection or influenza. It's very uncommon for an adult to present without a inciting event with an otitis media. If not, one should think of immediately of possibly a nasopharyngeal mass that needs to be ruled out. As you can see from this slide, referred pain can come from many different sources. It's up to the clinician to try and narrow down the possibility of where the referred pain is coming from. Obviously, a complete physical exam will need to take place. Keep in mind that discomfort can be elicited with palpation from the posterior neck, base of the tongue, tonsils, or even the TMJ area. If necessary, a flexible endoscope to rule out benign or malignant neoplasms should occur. If the exam is completely normal, the clinician may need to consider referral to a dentist for further evaluation of TMJ, possibly even a neurologist for the myofascial pain, neuralgia, or even headaches. On bacterial external otitis, I would like to point out the clinical practice guidelines as recommended by the American Academy of Otolaryngology Head and Neck Surgeons. They have strong recommendations that the clinician should recommend analgesic treatment based on the severity of the pain. Clinicians should not prescribe systemic antimicrobials as the initial therapy for diffuse uncomplicated acute otitis externa. This is typically bacterial in nature. They do recommend that the clinician distinguish diffuse acute otitis externa from other causes of otalgia. They should be able to assess the patient with diffuse otitis externa for factors that modify management of the infection, which would include lack of an intact tympanic membrane, tympanostomy tubes, diabetes, or immune-compromised state. Clinicians should prescribe topical preparations for initial therapy of the diffuse uncomplicated acute otitis externa. And if the clinician needs to enhance the delivery of the topical steroids, they would need to be able to debride the external auditory canal, place a wick, or possibly even both. Clinicians should be able to prescribe a non-ototoxic preparation when the patient has a known or suspected perforation of the tympanic membrane. This would include a tympanostomy tube. Clinicians should reassess the patient who fails to respond to the initial therapeutic option within 48 to 72 hours to confirm that the diagnosis is correct.